everyone. Thank you for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to empower families of premature babies through support and education. This Preemie Chats series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here every Friday, we talk with experts, researchers, and parents who share with us their experience and knowledge. Also on our website, canadianpreemies.org, parents will find all kinds of resources and support. One of our programs is the Parent Care Program. We are offering 4 free therapy sessions for families who are currently in the NICU up to 3 years post-discharge. To get more information about the program, visit the website on the Parent Resource page. And today we're going to talk about asthma and the premature babies. Dr. Moraes will discuss the underlying biology leading to a diagnosis of asthma and also discuss the biology associated with lung disease in premature babies and how and if these 2 different lung diseases are related. And I have joined me here live from Toronto, Dr. Moraes, who's being a staff respirologist at SickKids in Toronto since 2008. In addition to the severe asthma clinic and the aerodigestive clinic, Dr. Moraes also cares for ex-premature babies in the chronic lung disease of prematurity clinic. Dr. Moraes, thank you so much for joining me here today. What a pleasure to have you.
Well, it's a pleasure. I appreciate it very much, the invitation, Fabiana. It's very nice to speak here today.
Yes, and this is a topic that many parents have asked us throughout the year, and everybody's very curious to learn more about asthma. So I'm going to share your slides here, and you can take over the floor. And for all of you watching us live on Facebook or YouTube, please do send your questions and your comments, and we're going to address them at the end of his presentation. Thank you.
Perfect. And just to make sure you can see my slides okay?
Yes, perfect.
Perfect. Okay, great. So thank you very much, Fabiana. And as Fabiana mentioned, today I'm going to talk about asthma and premature babies. And hopefully you'll have some questions. So I'll spend about 30 minutes or so and just talk about my sense of how asthma comes about and why some children have asthma and some do not. And then talk about the lung disease that is sometimes seen after children are born prematurely and whether these 2 processes may be linked. And then there'll be lots of time at the end, again, for questions. So first off, one of the things that often is asked is how common is asthma? And asthma is actually one of the more common, if not the most common chronic disease of childhood. This is a picture from the Global Burden of Disease study where they looked at prevalence of asthma around the world. And you can see it does vary. So the darker red colors are more prevalent, upwards of 14% of the population. And you can see in North America here, it's probably between 6 to 10% of the population may have asthma. Some of the variability is related to how we diagnose asthma and whether people even get a chance to be diagnosed. And it's also in the definitions of what asthma means. But the take-home message is asthma is very common. When you think about asthma, you probably have a sense of some of the symptoms, but the most prominent symptom really is wheezing. So wheezing implies a very musical noise when you're breathing out. So it's on expiration. Kids and adults will often complain of shortness of breath or tightness in their chest, and often you'll have coughing as well. Coughing is very non-specific, and if you have kids, you know they cough for almost anything. Some of the other things you'll appreciate is that sometimes these symptoms are worse at night, and again, that's very common in kids. So these are relatively non-specific types of symptoms, but it's important to remember the wheezing. The other thing to remember is that asthma symptoms come and go, so they tend to be episodic. They're not there all the time. When you think about what's going on to explain these symptoms, what I tell people is that to me, asthma is your lungs overreacting to things. And so your lungs or your body will see a certain exposure or stimuli, and instead of just having a little bit of a runny nose or a cough, your lungs tend to get inflamed and overreact in a way. There's different biologic mechanisms that explain these symptoms, and I can tell you what we tell medical students. So one of the processes is what we call chronic airway inflammation. And so if you look at the lungs, you'll see that there's always a baseline amount of inflammation, which means like the lungs are always ready there to overreact. There's a process called reversible bronchoconstriction, So we call your airways bronchi, and constricting just means they become narrow. So reversible bronchoconstriction just implies that when the lungs are irritated, that you can see that narrowing of the airways. Airway hyper-responsiveness, again, implies this overreaction process, which can be measured. And I'll show you some examples of how we can measure that. But again, it's the idea that the lungs tend to overreact compared to the average person. The lungs of an asthmatic will overreact to a given stimuli. And airway remodeling is a broad term that implies if you were to take a biopsy or look under a microscope, you can see structural changes in the lungs of kids and adults with asthma. And some of those structural changes may explain why kids and adults have symptoms. So this, the previous slide was a bunch of words, and this is some pictures that will help illustrate why it can be hard to breathe. So again, this is a normal, healthy airway on the left side. You know what? I'm not a surgeon, and I don't know whether you can see my pointer or not, but I always get my left and right mixed up. But anyways, where it says normal bronchiole, you can see a normal open airway, and the opening there, the lumen, as we describe it, the tube is very open, and so air can move in and out very nicely. You can see there's bands of muscle that are around the airway, and they're not tight. You can see that the airway wall is not thickened, and so it's fairly easy to breathe. And if you contrast that to an asthmatic bronchiole, now obviously this is a cartoon where people have taken this to an extreme level, but you can see that first the muscles are now tight, and so that's contributing to narrowing of the airway. The airway wall itself is much thicker, and that's associated both with a little bit of due to a little bit of inflammation, and also potentially the remodeling, where you get increased number or increased size of the cells. And you can see the end result is that there's less space for air to move in and out. And this leads to the symptoms of wheezing and shortness of breath. We can measure a lot of these things. So this is lung function tests from a kid who has asthma. And on the side there, you can see these little letters, FVC, FEV1, etc. The main number we look at is something called FEV1. That stands for forced expired volume in 1 second. Basically, how much air can you breathe out in 1 second when you try your hardest? And this is a respirologist's kind of go-to number when we're just getting a sense of lung function. Basically, how much air can you breathe out in 1 second when you try your hardest? And the first number, the 2.26, is what was measured. That's to about a little over 2 liters of air came out when this 14-year-old child tried to breathe out as much as she could. And the next two numbers are actually predicted values, the lower limit and the upper limit of a normal range based on how tall this girl is. So we have a lot of reference ranges based on your height and whether you're male or female, and your age as well. And so the computer can generate a guess, where should this kid be blowing in 1 second? And that's where the next number comes from, the 78% predicted. So this child has an FEV1 that's 78% predicted. That's not necessarily bad or good. It's just in the lower limit of the normal range. But what's interesting is that when this child receives some Ventolin, so the blue puffer, if any of you guys have ever seen that, you can see the post values. So you see that red post. The FEV1 increases by, it says 12%, and so it goes from 78% to about 88%. So this is an example of reversible bronchoconstriction, because that blue puffer, the Ventolin, will relax the muscles in the airway and open things up. And this is something you can see in children who have asthma. Interestingly, you can also see this in premature babies and anybody who's been ventilated potentially for a prolonged period of time. But anyway, this is just to show you that we can actually measure reversible bronchoconstriction in the lab. The second thing I wanted to show you was this number lower down here where it says exhaled nitric oxide. So nitric oxide is a gas that's produced by many cells, including the lining of our lungs. And what people have found is that children and adults who have inflammation in their lungs often will make more nitric oxide. And we call that exhaled nitric oxide. So how much nitric oxide is being produced? And it's measured in parts per billion. Now in our lab, the normal range is probably less than 20 to 25 parts per billion. And this child you can see is at 41. So that suggests that there's some airway inflammation going on. So when I see this overall lung function, what I see is someone who has evidence of some airway inflammation and has evidence of reversible bronchoconstriction. And so this gives me some objective evidence that their symptoms, if they have any, are likely explained by asthma. Now, I mentioned airway hyperresponsiveness. Now, sometimes kids will come and their lung function is completely normal. It's in the normal range, but they still have asthma. And that's because, remember, if you're not seeing your trigger and if you're not unwell, your lung function may be very much in the normal, healthy range. So what we can do then is we can actually do different tests to see whether your lungs are hyper responsive. There's different things we can try and I guess irritate your lungs with. Some people will use allergens in a specialized setting. Some people will use exercise. There's even ways you can use a compound called mannitol, which kind of dehydrates the airway a little bit. But the vast majority of people will use a drug called methacholine. And so methacholine will do the opposite of that blue puffer, the Ventolin. Methacholine will actually cause your lungs to constrict a little bit, your airways. However, the average person can inhale quite a lot of methacholine before that would happen, whereas someone with asthma just needs a little bit. And so that's what we're seeing here is a child who has airway hyperresponsiveness because we end up using a very small amount of methacholine. So these lines here on this side, you can see these numbers, 120, 180. So 100% is basically where his lung function starts. And that's where that first little B you can see there, it shows baseline. So his lung function for this little boy is starting at 100%. And then the next dot, if you move over, if your eyes move over, you see it's close to 0.05 in terms of the concentration in milligrams per mil of methacholine. So we give this child a little bit of methacholine to inhale, and we measure his lung function again. And his FEV1, the amount of air he can breathe out in 1 second, doesn't change at all. We give him a little bit more. It doesn't change on the third dot there. But then this next to last dot, the one at 1 milligram per mil, you can see that the FEV1 has dropped after he inhaled that. And it dropped by a little over 20%. And so that's considered a positive methacholine challenge. It tells me that this child is overreacting or having airway hyperresponsiveness to methacholine. You can see that with Ventolin, it bops back up. So you can see it goes back even a little bit higher than his baseline. The average person could inhale higher than 16 milligrams and not have any problems. So 1 milligram is considered hyperresponsive. So we don't do biopsies on kids routinely, but if you were to do a biopsy, this is where you can see aspects of remodeling. And, I'm not a pathologist, and I don't know if anybody in the audience is a pathologist, but you can basically see just by looking that there's a difference between what's considered a normal or healthy airway and an airway from someone who has a diagnosis of asthma. There's just, everything looks thicker and more purple, and the purple just means there's more cells and more inflammation. And often these are immune cells, these are smooth muscle cells, these are things, and mucus producing cells. These are all things that will contribute to the lung having a harder time when we're trying to get air in and out. Now, I mentioned, the idea of asthma, but one of the things that I put this slide here for is just to illustrate that asthma is a label that probably encompasses a number of different processes. So it's a bit of an umbrella term. And so some people will talk about asthma endotypes, which means that there are different ways you can end up having symptomatic asthma. And there's different labels for this. So people will talk about allergic asthma, they'll talk about late onset non-allergic asthma. There's asthma that's associated with obesity. There's earlier asthma that seems to go away as you get older. And so there's different underlying mechanisms that may be explaining these different forms of asthma. And I think as we learn more about these, we'll get much better at tailoring therapy. But for now, the majority of the kids that we see are generally allergic asthmatics. So they're kids that tend to have allergies and tend to be people who have eczema and often food allergies. And a lot of their lung problems are related to this. And controlling an aggressive allergic response is often part of what's going to help them. When we talk about why do people have asthma, that's a very complicated question. And I'm actually part of this study called the Child Study, where we've recruited about 3,500 families from across Canada. And the whole point of this study was to try and figure out why some kids get asthma and some kids don't. And we've been following these children from before they were born, so when they were still in utero. And now the kids have just finished their 8-year visit, and we're going to be starting the 13-year visit next year. And what's interesting is that a portion of these kids did end up being diagnosed with asthma. So at age 5 and age 8, when we saw them, there was what you'd expect, anywhere from 5 to maybe 12% of the kids had asthma. And we can start to see what are the determinants. Why are some of these kids having asthma? And there's some interesting stuff coming out where, I mean, obviously genetics plays a bit of a role in terms of allergic patterns in the family, but there's also a role for infections early in life. There's a role for a microbiome. So you've probably heard about the microbiome, the bacteria that live in and on us. And the gut microbiome in particular, we've come up with a lot of data to show that changes in the gut microbiome can impact asthma. And so I think we have an imperfect understanding as to why some children have asthma and some do not. But certainly we're learning more and more about this. And I think the ultimate goal would be to understand it to the point that we could actually prevent asthma. But at this point, we don't have the ability to prevent asthma. And we're still learning more about that. Now, asthma causes should be differentiated from asthma triggers. So once you have asthma, there's different things that will trigger the symptoms. And these are probably things you recognize. And this is a picture I've lifted from the SickKids website about kids' health. But most commonly, about 80% of people who have asthma will be triggered by viral infections. And so that's why that's there. But there's a number of other conditions that kids and adults will say, oh, this is something that triggers me. And everybody probably has their own little individual laundry list of either allergens or paints or perfume or smoke or exercise or different things that can trigger their symptoms. The other thing to keep in mind, especially when I see kids who are being treated for asthma, is there's a number of other conditions that often accompany the diagnosis of asthma, and they're important because they can also contribute to breathing type symptoms. So rhinitis means inflammation in your nose, and this is often related to the next point, which is allergies. So those two can often be independent of your lung disease, but they can contribute to breathing problems. So if your nose is all congested and you try to sleep at night, kids will be coughing like crazy. There's also some suggestion of there's something called the unified airway hypothesis, where they say that if you have inflammation in your upper airway, in your nose, that can lead to inflammation lower down. And so certainly a lot of the kids I see will have inflammation or allergies that contribute to their symptoms. Anxiety is very common as well. Now, I mean, if you can't breathe, you're going to be anxious. And so being short of breath or having asthma can often contribute to a feeling of anxiety. But the other direction also occurs, where if you're anxious, it changes your perception of being shortness of breath. And it can certainly make your perception worse. And because we rely a lot on symptoms, a lot of times severe asthma is related to underlying severe anxiety. Vocal cord dysfunction is something I also see often combined with asthma. And vocal cord dysfunction implies that your vocal cords, which kind of sit up here in your throat area, they're supposed to open when you breathe in. But in a subgroup of kids, especially teenagers, you'll actually see them move paradoxically. So instead of opening, they actually close a little bit when you're breathing in. And that can make it very hard to breathe. One of the big differences between asthma and vocal cord dysfunction is vocal cord dysfunction gives you a noise when you breathe in. So more of a kind of noise, as opposed to with asthma, you have the noise when you breathe out. There's a lot of information about obesity and how that can contribute to inflammation. So it's not just that, hey, if you're heavier, you feel more short of breath. Fat cells actually elaborate a lot of different mediators that can alter your immune function and inflammation in general. Smoking and vaping is one of my pet projects, and certainly that is something that exaggerates all lung disease. And I have colleagues that are interested in sleep apnea. And again, it's interesting to show that obstructive sleep apnea, so big tonsils, big adenoids, snoring at night, that can also contribute to asthma symptomatology. Now, I show you this just to let you know that there's a pretty defined pathway for managing asthma. And so this was published in 2017. I think almost every country and every asthma guidelines committee will publish their approach to managing asthma. And it usually starts with confirming the diagnosis. And this is really important because once you confirm the diagnosis, you essentially run up this pyramid of medication, and you keep running if the person isn't getting better. So if the person's not getting better, it could be because they need more medicine, or it could be because they don't have asthma. And so it's really important to confirm the diagnosis as you're thinking about this. And generally, most children will respond to a very low dose of inhaled corticosteroid. So you'll see these orange puffers generally. Some of them are purple or brownish, but that's the color. And the main goal of these inhaled steroids is to stop the lungs from overreacting. They're a tough medicine to take because if you take them properly, nothing happens because you're preventing things. And so you're always wondering, did nothing happen because my kid doesn't have asthma, or did nothing happen because I'm preventing something? And so I often find that challenging for families. Anyway, after inhaled steroids, there's a few other classes of medications. You can add in long-acting Ventolins. You can add in anti-allergy medicines like leukotriene receptor antagonists. And you just climb the way up. And eventually, if you end up on a lot of medicine and you're still under control, you end up being labeled as severe asthma. And so we have a severe asthma clinic at SickKids, and that's where I end up seeing a bunch of kids. It's probably not a fair representation of the bulk of asthma, because the majority of children with asthma will do very well with very small amounts of medication. I put this in here just to illustrate that there are a number of conditions that can be labeled as if they have asthma. So I've seen kids, and I didn't put this up just to say, look at all this other stuff, but I've actually seen kids with each of these diagnoses in the end, but they came to me because people thought they had asthma. And they ended up not having asthma. They ended up having something else, and that's why they weren't responding to a low dose of medicine. And on this list, I put prematurity, in part because being born prematurely, you can often have signs and symptoms that mimic asthma. Now, it's not to say that the two can't coexist, but I think that they are different entities. So let me tell you a little bit about premature lung disease. So we also have a clinic at SickKids that we call the CLDP clinic. CLDP standing for chronic lung disease of prematurity. So different doctors will kind of throw this term around, but for me, what it means is it's just a general catch-all phrase, meaning, I was born prematurely and now I have breathing problems. So it's just kind of this is what it is. I'm not measuring your carbon dioxide or your oxygen or anything else. It's just if you have breathing problems and you're born prematurely, you can come see me in this clinic. Now, this is different from bronchopulmonary dysplasia, or BPD. So BPD was recognized many years ago before surfactant was developed, and you probably know if you remember the nursery that sometimes when babies are born early, they're given surfactant, and that helps keeps their lungs from collapsing. And what surfactant did is it changed what BPD looked like, and it changed which babies were survivable, basically, because it allowed a 34-weeker to have a very uneventful course. Whereas in the olden days, if you were born at 33 weeks without surfactant, you were in trouble. So bronchopulmonary dysplasia now, some people call it the new BPD because it's different from before the 80s. But anyways, bronchopulmonary dysplasia is really defined on how much oxygen you need. And generally, the amount of oxygen you need is assessed at 36 weeks gestation. So after you're born, we keep counting how many weeks gestation you were. And if you still needed oxygen at 36 weeks, then you fit into this criteria. So it is much more of a clinical label. It's saying, hey, you need oxygen, we'll call you BPD. So why do some kids get BPD? So really the heart of it is something we call alveolar simplification. So alveoli are the little air sacs at the end of your lungs, and they're simplified. They're not as thin as you would expect. And I'll show you a picture on the next slide. But I wanted to mention that associated with the airways being simple, you also have simplification and less development of the blood vessels as well. So that's where that vascular part comes in. And that's important because while we worry about breathing and air moving in and out, having reduced blood flow and higher pressures in the blood can also contribute a lot to the symptoms as well. So this is a histology slide or an embryology slide that we torture students with, and we ask them to remember the different stages of lung development. And when you're a baby in utero, you progress from the embryonic stage where you have just basically lung buds that don't do much, to the pseudoglandular phase where you start to see more branching, the canalicular phase where you now start to see something that we would call primitive alveoli, the saccular phase where you can actually see little sacs, and then the alveolar phase where you get real units of lung that are capable of gas exchange. So you can see by the dates at the bottom here that when a baby is born prematurely, their lungs are quite immature. And this is what we mean by alveolar simplification. Their air spaces just do not have the ability to exchange gas. The whole point of a mature lung, so when you go all the way to the end where they have these light blue alveoli, the whole point of the lung is to maximize surface area for gas exchange. So in an adult lung, if you were to spread out all the alveoli in terms of surface area, you'd have a surface area about the size of a tennis court. So it's really a lot of surface area for gas exchange. And you have probably an Olympic-sized swimming pool worth of volume of blood that kind of interacts with that airway. And so it really maximizes gas exchange. And by that, I mean oxygen coming in and carbon dioxide going out. But when you're in this canalicular and saccular phase, you don't have that. Not only do you lack the surface area, but the space between blood and airway is quite thick. And so that leads to difficulties in gas exchange. And that's why babies require breathing support. Really, the thing that helps kids is just time. But in that time, they need support. What we've also come to realize over time is it's not just the structure, but there's other things that impact the expression of BPD or lung disease. So genetics, we're starting to realize that, and I guess genetics touches everything, but starting to realize that genetics plays an important role. And then all the things we do to keep kids alive, the ventilation, the oxygen, and then different things that can contribute to inflammation, whether it's infection or aspiration, those things all result in a bit of a hodgepodge where some kids will have more or less problems for different reasons. And in general, there's three kind of processes that contribute to a kid having problems after they leave the nursery. One is parenchymal, or the actual lung tissue being damaged, and that can be because of not only impaired development, to start with, but all the stuff we do, the ventilation, the irritation, etc. Then there's vascular changes, so the blood vessels, which again relates to what you start with and what all the irritation that happens afterwards. And the third thing that sometimes people forget are the large airways. So the large airways can sometimes be a little more collapsible. A little bit different than in an asthma person, because in asthma, it's usually the small airways. But in kids who are born prematurely, it's often the large airways. So the cartilage may be less developed, and so the airways are a little more floppy. By the time they come to my clinic, the things that I find affects the kids the most, and so the things that I look for. So some children will have, indeed, because of the small blood vessels, will have what we call pulmonary hypertension. So it's high blood pressure in the lungs. And that can contribute to their ability to tolerate infections and just the amount of work they have to do. Tracheobronchomalacia is a fancy word for saying that their trachea, so the upper airway or the bronchi, the large airways, can be collapsible. Malacia just means soft. And so when the airway is soft, it contributes to your work of breathing, because every time you take a breath in, your airway's collapsing a little bit, and it makes it a little bit harder to breathe. The other things that we have maybe a little more control over, although I don't know how much, infections, and that's why all these kids will, get RSV prophylaxis and flu shots. Smoking is again, a big factor that impacts babies, and I wish we had a stronger approach to smoking cessation in the nursery. Reflux or aspiration, so food. As a respirologist, I'm very selfish. I don't care how you eat as long as it doesn't go in your lungs. And then there's a few other issues that you can sometimes see in some kids. Edema, meaning fluid coming into the lungs because of heart issues, and sometimes subglottic stenosis or vocal cord issues. That just implies that the airway may have some scarring from the endotracheal tube or some damage to the vocal cords that can contribute to work of breathing. So really, the management is really just support for kids who have breathing issues. So oxygen until they don't need it. Make sure they've got good, safe nutrition. Very, very occasionally, we'll see kids that benefit from ongoing diuretics or water pills to pee off extra fluid. But most of the time, by the time I see kids, we can wean off the diuretics. The bronchodilators and the steroids outside of the NICU are medicines that I don't find are useful on everybody. So it's a real minority of kids where I find that this makes a huge difference. And then depending on other issues, if they have pulmonary hypertension, then we manage that. And immunizations is important as well. So in terms of long-term outcomes, so Paul Moore, who's a respirologist out in the States, reviewed a ton of articles, and there were over 60 published since 1990, and he did this review maybe 5 years ago. And what they found was that compared to term babies, premature babies are more likely to have breathing problems, more likely to have objective measures of airway obstruction. So these are the lung function tests that I showed you with asthma. They may also have reversibility with bronchodilator. And so based on that, based on the fact that they have symptoms, they have objective measures, they're also more likely to be diagnosed with asthma. And they're more likely, if you were to do a chest x-ray or CT scan, to see structural changes. And I can show you a study. This is a study that was done in Ireland, but this is very similar to many long-term studies. But what this group did was examine a bunch of babies who were now in their early 20s, and they said, hey, let's look back and see how many of them had issues. And they split the group into children or adults, I guess, that were diagnosed or labeled with bronchopulmonary dysplasia when they were little, preterm kids who did not have bronchopulmonary dysplasia diagnosed when they were little, and then term babies that were born in the same year but happened to be term. And then this slide just shows the presence of respiratory symptoms. And you can see that in this cohort, at least, a third of kids who were born early had breathing symptoms reported, compared to closer to 10 or 12% of term babies. And so you can see the bottom line here, the take-home message anyway, is that being born prematurely is associated with more breathing symptoms. And also that differentiating between BPD and no BPD may not help you identify an at-risk group. When they looked at who was labeled with a diagnosis of asthma, you can also see that the premature, ex-premature people were much more likely to be labeled with asthma. One of the things I wanted to show you was this slide. It's a slide from a journal called Seminars in Fetal and Neonatal Medicine, where they were talking about normal lung growth. And what you can see is that on the bottom here, they have age in years, and you start off at 0 and work your way up to 20. And you can see that a healthy person will gradually grow lung until they reach about late teens or early 20s, and then you get this gradual decline with time. You can accelerate this decline, which is somebody is doing here with a dotted line, and the most common way to accelerate this is with smoking. And eventually, as your lung function goes down, as you get older, you may become symptomatic. You may start to complain, oh, I've got a hard time breathing. And if it gets very low, it may even lead to your demise. But the average person won't reach that unless you're accelerating it. When you're born prematurely, on average, you probably start a little lower and you probably end up a little lower, even though you're constantly growing and maximizing your lung function. And then you'll also have this gradual decline with time. And I think the vast majority of kids who are born prematurely will probably not become symptomatic as they get older, unless they have a secondary insult. And so this is something I've been doing more, is counseling families and kids not to have that secondary insult. So part of the management is really about trying to prevent secondary things. So don't smoke, think about getting a flu shot, all the things that kind of common sense things to keep your lungs healthy and maximize lung growth. We're not at a point here to take you from the bottom curve to the top curve, but there are some cool investigators in Canada that are working on this, and some of you may know Dr. Bernard Thibault out in Chio. Excuse me one sec. And so he's got some really cool research with cell-based therapies, where he's hoping that he can actually augment lung growth. So in the future, there may be ways to actually take somebody from this bottom line up to the top line. But you can see that's the pattern. And so one of the things that's consistent with that is that if you were to measure lung function, so the percent predicted, you can see that people who are born a little bit earlier, and here the BPD does seem to differentiate, at least in this cohort, they do have a slightly lower lung function. And this will vary from cohort to cohort, but on average, kids who are born prematurely tend to have a slightly lower lung function. So that's what I wanted to say. Hopefully, you guys will have some questions, or I can answer some questions. But what I wanted to impress upon you is that asthma is very common. It's a chronic condition, and it is a bit heterogeneous, meaning that it's a bit of a catch-all phrase, and it's associated with episodic symptoms. So on average, you're okay, and then when you see your trigger, you have a hard time breathing, and that's hard time breathing is often associated with wheezing. But you can, in the majority of people, control this with a very low dose of inhaled steroid. Prematurity is also associated with symptoms, but this is a different type of pattern. It's generally a lot more of a structural thing and less about an overreaction. And it's something that may persist throughout life, but it's certainly something that generally improves as your lungs grow and as you get older. So I think that the two conditions, prematurity and asthma, have very distinct causes in terms of their underlying lung symptoms, but the actual symptoms and the management may end up overlapping. So that is what I wanted to say, and I will leave time here for questions.
Wow, excellent. Thank you so much for your presentation. I always learn so much here on Fridays. It's unbelievable. It's like we parents take a crash course in different aspects of medicine related to preterm birth. Amazing. So we have a lot of questions here. Let's start with a thank you first, and for its RSV season, asthma is acting up. I think you mentioned that a little bit with the viral infections going on in the community. And I think my question, last year we didn't see a lot of RSV. Did you see a lot of asthma? How was asthma last season?
Yeah, so that's very interesting. And I have a respiratory medicine fellow, Jason McConry, who's actually reviewing some of these data for us. And we're partnering with people in Edmonton and Vancouver as well, just to get a sense of what's happening around the country. But it's very clear that with the COVID pandemic, the lockdown, at least last year, we saw a dramatic decrease in viral infections. So there was almost no influenza. There was very little RSV. And most of the other respiratory viruses we did not see. So there's although everybody has heard of RSV and flu, there's a handful that we look for. There's probably about 10 different viruses that can trigger symptoms. And these viruses not only impact small babies, but they're a very common trigger for asthma. So with that, we also saw a tremendous decline in asthma attacks. And so there was much fewer asthma children coming into the emergency room and into the hospital, and we had fewer referrals to our clinic as well. And this isn't just something we saw in Toronto or in Canada, it's something that was described around the world. So the precautions that were designed to reduce the spread of SARS-CoV-2, of COVID-19, actually impacted many viruses. And as a secondary effect, it impacted a lot of diseases that are exaggerated by these viruses. What's interesting is as restrictions let up and as people started to get back together, the viruses have come back. So it's not like they were gone for good. They're coming back. It actually threw off the season a bit. And so you remember, if you remember looking after your babies when they were early, RSV prophylaxis had a very typical season. We give the antibodies maybe in October-ish, and it goes till March-ish. But some jurisdictions had to actually give it over the summer because RSV just suddenly showed up in the summer. And so yeah, it has been very interesting. Now the viruses are coming back, and we're seeing asthma come back as well, or the asthma attacks.
Thank you. And I'm just sharing here the link of the new materials that we created for this season to how to decrease the risk of infection on preterm babies. It's all in our website. So, but let's continue here because we have a lot of comments and questions from Ari. My daughter, born 31+2, was only on CPAP. She's 5 months old. She had a consistent cough since she was born. She doesn't wheeze, but coughs randomly throughout the day, almost daily. They initially told me it could be caused by her reflux, which has really subsided now, yet the cough persists. Could this be asthma?
Yeah, so it's a tough question to answer over the internet, I think. Um, um, a cough by itself often is related to reflux because you get a little tickle, things come up, and you don't even actually have to reflux all the way up and get it in your mouth, although sometimes that will happen. Even if you reflux midway up your esophagus, that will sometimes stimulate your lungs. It's almost like a reflex to reflux. And so you get a bit of spasm and irritation, and you can cough. It really depends on the pattern of the cough. If it's there all the time, it's probably less likely that it's inflammation related to asthma, and it's probably more of a baseline chronic condition, like either reflux or something else that's going on. But it would be good for someone to just listen to her cough, listen to her chest, and get a sense of what may help.
Okay, so here we have Sarah. Sarah, is there any screen that is automatically done for preemies to determine if they will develop any lung issues, or is it done only based on symptoms the child might experience? Thank you, Sarah.
Yeah, that's a good question, because in an ideal world, we would try and identify babies who are at risk, so that we could either prevent this or get referrals set up sooner. But I don't think we routinely do that. And so for children, it's often just how unwell they are when they're leaving the nursery. So if they need oxygen, then they'll end up coming to see me, or it depends where you live, I guess. But so in Toronto, if you need oxygen, that's a criteria for referral. But certainly it's symptoms, because there's a huge number of children that are born prematurely. You know that, and so not all of these kids will have breathing issues that require specialist care, and so it does end up being based on symptoms for now. Yeah.
Right. So my question is because, my son who actually was your patient, he was discharged home on oxygen. He had a lot of breathing issues, and the community doctor wanted to diagnose him with asthma. And I kept bringing him back to you, and you said it's not asthma. So are the pediatricians in the community aware of all these lung issues that preemie babies can have to differentiate the diagnosis?
Yeah, it's very tough, and it's tough because the type of kids that I see at SickKids are very different from what you see in the community. And so some of the things that I say don't make sense in the real world. I mean, I'm saying the real world in a silly way, but by the time kids come to see me, the unusual things are actually much more common in some ways. So if you're in a community, the vast majority of kids that a pediatrician will see will fit the picture of asthma, for example. So most people who have a bit of cough, a bit of wheeze, you can treat them as if they have asthma, and that's fair. But if you're born prematurely and you don't have a lot of allergies, you don't have eczema, and your symptoms are more coughing and less wheezing, and it's just there all the time, to me, it's less likely that this is an overreaction thing. It's less likely that your lungs are overreacting to something, and it's more that they're just starting off small, and they're having a hard time because they're small, and any little insult is just an added straw to the camel's back. And what we need for those kids is just protecting them and giving them time. And that's where it's important, because with someone with asthma, it's not that you need time or protection. I mean, everybody needs protection, but with asthma, a low dose of inhaled steroid, will return you to a new baseline. Whereas someone who's born prematurely, you just need to give them some time and let their lungs grow. Now, having said that, a low dose of inhaled steroid probably won't hurt, but, but it probably won't help either. So that's my sense.
Okay, so one more question here from Jonathan. Thank you for this presentation. Have you seen recent data that speaks to how early human milk nutrition might help with alveolar development and thereby decrease BPG as defined by O2 at 36 weeks gestational age? Thank you,
No,
Jonathan.
so Jonathan, if you have cool data like that, you should send it to me. But I do think that people are, I mean, you probably remember this, but people have always been very aware of the beneficial effects of breast milk. And we're learning more and more about how breast milk can affect many, many different things, um, including potentially the lungs. But I haven't seen data to suggest that early feeding will improve alveolar development. I haven't seen that. But one of the things I've seen with the child study is really it's made me change how I think about breast milk. I used to think, oh, breast milk is good for the baby, but what I've realized now is breast milk is probably good for the baby's bacteria. Like I almost feel like we're feeding the microbiome as opposed to the baby, and you actually optimize the microbiome, which then indirectly helps the baby's health kind of have a nice trajectory. It's an interesting idea that I think people are looking at now is how breastfeeding can affect the microbiome.
So there's a lot of research going on in Canada with that, which is
Yeah.
great to see. So one more question here from Katerina. So this one you need to translate to me. So is there a difference in quality of life with FETV1 80% versus 100%, besides not being able to be an ultra athlete?
So I appreciate the question. So what just to remind you, Fabiana, the FEV1 is a measure of lung function. And so on average, most people will be about 100%, and there's a bit of variation. Some people have a big nose, small nose, you have big lungs, small lungs. So on average, most people will fit between 80% and 120% of the reference range. And the question is there a difference in quality of life just based on that? No, I don't think there's good data to show that. I think on average, though, lower lung function is probably associated with slightly reduced exercise capacity and and other kind of adverse consequences. But at an individual level, it would be very hard to pick someone out of a crowd and say, "Oh, you must be 80%. Oh, you must be 100%." What's really interesting though is how well an individual can adapt to that. So if you start off at 80% and you've been 80% your whole life, that's your normal, and you can run around and play, and you will achieve what you need to achieve. If you start off at 120% and I suddenly reduce you to 80%, you'll notice. You'll notice that difference, and you'll have a little bit of a harder time. But I've seen kids where, for different reasons, we had to take out a whole lung, and they're running around and doing taekwondo and stuff, and their quality of life is probably okay. Their exercise capacity would be a bit reduced, though.
Right, thank you. So I have a question from Leah. Leah is a mom from IWK in Halifax, and she's a parent partner there too. So she asked, my 28-weeker has regular lung function test and doesn't do well. She has been diagnosed with asthma. However, shows no signs of asthma. She never says she has a hard time breathing. However, she's on puffer twice a day. Could her function continue to improve? She's 8 years old.
She's 8, and she's in IWK. I don't know if she sees Demas, who's one of the respirologists out there, but it might be worth going to see a respirologist and just refine the diagnosis of asthma and just see is this something that's real or not, because if she has no symptoms, then it would be important to get a sense of what are the puffers doing and what's helping. I think in terms of will her lung function improve, will things change? So the way that the FEV1, the percent predicted works is that as you get taller, we keep expecting more of you. So the actual absolute amount of your lung volume will continue to grow. So I do expect that as she gets taller, she's only 8 now, presumably she'll keep getting taller, um, her lungs will continue to grow. She'll grow new lung, little alveoli, etc., and her lung function will grow. But in terms of the percent predicted, it may always stay roughly around the same. So if she's at 70% now, it may stay at 70%. Now, there is a caveat. Some little kids have a hard time blowing hard. And so the technique requires a lot of effort. And so if the effort isn't reproducible, sometimes the numbers are low, but it's not because the lungs are actually a problem. It's just the technical issues related to the thing. And so as she gets older, we may actually get a better sense of what her lung function is like.
Okay, that's great. So question that came from our private group, are kids with asthma or chronic lung disease at higher risk of having COVID?
Yeah. So this is a question we get a lot. And initially before COVID started, if you were to ask me, hey, would I expect kids with asthma and ex-premature babies to be at high risk for an imaginary pandemic virus? I'd say, yeah, I would, because, viruses will trigger asthma. It's a very common trigger. And we know that in the first couple of years of life, a huge cause of problems for babies that are born prematurely is RSV and influenza. So I would have expected that you'd see a similar pattern with SARS-CoV-2. But that's not something we've seen. So at SickKids, we're actually, when all the other hospitals were full of adults in the intensive care unit and in the emergency room, we were not. And we actually had, our intensive care unit ended up taking grown-ups because the grown-ups were so full that our intensive care unit offered to take some young adults. And so when you look overall at the pediatric population, it's still the case that kids are having milder disease. And when you look at the kids who are having disease, we're not seeing an enrichment of children with asthma or ex-premature babies. And I'm not really sure why that's the case. I think the message would still be that you should treat this virus the way you would treat any virus, that it may aggravate things. But I don't think there's a special reason to freak out about SARS-CoV-2 above and beyond the general population level of freaking outness, if that makes sense.
So this is a good news for parents because obviously we always freaking out about any virus, and with this new one, I think parents were like, "Okay, what do I do now?"
Yeah.
We all panic in the beginning, so it's reassuring that it's not affecting our babies as much as
Yeah.
other people.
Well, one thing I just want to say, and I'm aware that this is going to be recorded and people will look at this later, is that what we know about SARS-CoV-2 seems to change. Every few months we're learning new things, and so what I'm telling you is based on what we know now. And I think maybe some people say it's interesting, some people say it's annoying, but what's interesting is that things change with this virus, and we're learning new things with time. My hope is that these new variants that are coming out will be actually, even if they're more transmissible, I hope that will continue to be less severe, because it is actually in the interest of the virus to not hurt us. It's in the interest of the virus to just spread around like crazy. And so hopefully it can do so without hurting us.
Right. So we have one last question. Do children ever outgrow asthma as young adults? Thank you for joining us, Josette.
Yeah, so that's a good question, and the answer is, of course, they can, and part of the reason they can is because, this label of asthma is a hodgepodge, and so depending on what the underlying, what was the reason for this expression of the disease, things may change as kids get older. And so there are probably about 40% of children will wheeze with a virus when they're toddlers. So it's a huge number of kids. And a lot of these wheezing children are labeled with asthma. But by the time you're older, you're looking at numbers of only about 10%. So there are a huge proportion of people that will have wheezing and have this label of asthma. And as they get older, they will, in a sense, outgrow it. And some of that may be because their underlying mechanism was just, small airways that have now grown up. But even allergic asthma can change with time, and people's bodies change with time. What we've also seen is around the time of puberty, um, there's a dramatic shift in that before puberty, it tends to be boys that have a harder time breathing and more commonly are labeled with asthma. After puberty, it shifts, and you start to see a lot more girls being labeled with asthma. And so there are changes over time. I think when it comes to asthma management, what that means is that we should be trying to use the least amount of medication possible to prevent that overreaction. And so there's always a little bit of push and pull where you are trying to control symptoms so that kids and adults aren't overreacting to their triggers. And then once you get a period of control, you try and see if you can ease back a little bit. Now, for some people, when they get older, they've done this enough that they know, no, this is the way I am. This is my baseline. I'm done. For kids, it's often a constant kind of push and pull because they're new people. And even though some medical charts are quite thick, the reality is they haven't been around very long. And so it does take a bit of experimenting in some ways to get a sense.
That is so great. And Dr. Moraes, I'm sharing your website here from the SickKids portal. There's a lot of good information there. And I will thank you. So I don't think you have any more comments here or questions. So Dr. Moraes, I'm really grateful for your presence here today. Thank you so much for sharing your knowledge and your expertise with us. It's great. Always learn so much from you.
Perfect. I appreciate the invitation. I hope you have a good weekend too, and then happy holidays.
Thank you. Stay with me. I'm just going to wrap it up. And to all of you watching us live today on Facebook or YouTube video, thank you so much for joining us. The video of today's session and all the videos from our previous chats are available on our website, which is right here at thecanadianpreemies.org. I also want to thank our sponsors, AstraZeneca and Waterwipes, for their ongoing support to our education sessions. And we are a charitable organization, and we believe that through education and support, we can empower families, ensuring they are ready to care for their premature babies. Visit our website, consider making a donation. Together, we can create a brighter future for all our families. And I see you again next Friday, 1 p.m. Eastern Time. Stay well.